What's going on, everyone?
Hi, Avi.
What up? Okay. What do we got over here?
Interface dermatitis.
All right. Interface dermatitis. And what are our criteria for determining if something's an interface dermatitis?
Inflammatory infiltrate at the DEJ, which this has. And this one is a band-like pattern, so it's lichenoid interface. And then you can also look for whether or not there are vacuoles in the epidermis.
Okay, so infiltrate at the DEJ. That's so obscuring the DEJ, that separates which two types of interface dermatitis.
Vacuolar and lichenoid, right?
Okay. Yes, lichenoid vacuolar. And then, but how do we tell what are the three things we look for to tell if something is a true interface dermatitis versus just inflammation at the DEJ, which is not that is a non-interface dermatitis.
I think
You mentioned one of them, so vacuolation at the DEJ.
you also need RBC extravasation.
RBC extravasation is not part of the criteria for interface dermatitis. That is part of the criteria for something else.
Is it pigment dropout and
Pigment
dead reds?
dropout
Dead reds.
and dead reds. Those are the three. What is RBC extravasation a criteria for?
That's for pleva. Is that what you're trying to get at? Or
Not a criteria for
Vasculitis?
yeah, vasculitis, leukocytoclastic vasculitis. You need RB red cell extravasation. Now you can see red cell extravasation in other things, but just telling if something's an interface dermatitis, a true interface dermatitis or not, there's really just three things to look for. Vacuolation of the DEJ. Does this have that?
yes.
Yes. Dead reds. Does this have that?
Yes.
Pigment dropout. Does this have that?
Yes.
Yes. So is this a true interface dermatitis?
Yes.
Yes.
It is. Good. Okay, that's step one. Step one, before we even talk about lichenoid or vacuolar, is it a true interface dermatitis? Your answer is yes over here. So now what type of interface dermatitis is it? Are we in the vacuolar or lichenoid category?
Lichenoid.
And why are we in the lichenoid category?
Because it's lichenoid band.
It's a band, and it's can you make out the DEJ?
No, not really.
No, it kind of, see how it obscures the dermal epidermal junction? That's characteristic of your lichenoid interface dermatitis. Okay. Now that we have classified this as a lichenoid interface dermatitis, what's our differential?
Lichen planus, but this one does not have the sawtooth ready ridges, so that kind of becomes less likely. Well, maybe it does. Okay, I keep lichen planus, and there are no EOs and no parakeratosis.
Okay, good. That's important.
So that
it's
helps.
important to look for EOs. That's good. And it's important you mention that. So there are no EOs. I agree. So that eliminates a number of things off. Well, that all but eliminates a number of things off our differential. What does that militate against if there are no EOs?
Lichenoid drug.
Okay, lichenoid drug. Good. So
I mean, you drew them out, Robbie.
Never mention this to Dr. Neat, by the way. But what's this?
Wedge-shaped
hypergranulosis.
Wedge-shaped hypergranulosis. Right here. Okay. Orthokeratosis, wedge-shaped hypergranulosis. Now, it's hard for you. The reason you didn't see that sawtoothing is why? Well, it's hard to see it if you're obscuring the DEJ, so it can be hard sometimes. But this kind of does have it. Let's see. Anyway, with all of those findings, here, let me see if I can convince anyone. Not the most striking. But what with these findings, okay, so you have a lichenoid interface dermatitis, wedge-shaped hypergranulosis, keratosis, and something that has at least vaguely resembling. You can see this too. Sometimes you can get these artifacts that happen as well. So what do we think? And no eosinophils. What's like the top of our differential now?
LP.
Okay. Yeah. Pattern here.
Superficial perivascular. Yeah, like superficial perivascular. It doesn't look lichenoid.
Does not look lichenoid. Okay. So there is superficial perivascular. Is there any other patterns?
Vacuolar inefficient.
Yeah. And you're saying okay, so you're saying vacuolar, so you've decided vacuolar interface, so you've decided it's a true interface dermatitis.
Mm-hmm.
Good. It is.
Dead reds. We see inflammation at the DEJ. We see pigment
I don't see
dropout.
wait, where's the pigment dropout? Oh, I see it.
Yeah. All right. So you got pigment dropout, you have vacuolization of the DEJ, you have your dead reds. All right. So we agree this is a true interface dermatitis. Can you make out the DEJ? Yes, you can. So you've decided it's not lichenoid. Cool. And there's a decent amount of scattered dyskeratotic keratinocytes. What's our next step? What are we going to look for?
EOS.
EOs. Okay. Any?
I don't see any.
Yeah, the rare if there are. So what is your differential? Let's look at that other slice. Okay. A lot of dead reds here, guys. Also a lot of inflammation. What are we thinking?
Could be like EM, GVHC.
Yeah. Yeah. EM is going to be like when you see this, EM is going to probably be at the top of the list. I mean, this is a lot of, so it's a decent amount of death here. There's a lot of scattered necrotic keratinocytes. But why is it not, say, SJS?
I thought SJS was more inflammatory. Like you'd see more EOs or more inflammation.
So it's actually the opposite. SJS is less inflammatory.
Hmm.
In fact, that's the hallmark. The hallmark is the death is out of proportion to the amount of inflammation that you see. Whereas in EM, the other part of the spectrum, the death is kind of in line with what you would expect to see with the inflammation. So there's a decent amount of inflammation here. There's also a decent amount of death here. It's adding up. Let's see if I can. Compare that to this.
Oh,
How
yeah.
much death do we have?
There's a lot, but there isn't actually a lot of inflammation.
Yeah. In fact, you can even see a split over here, right? So this is better for what?
That's better for SJS-TEN.
That's better for SJST. Yeah, good. What do you guys think of the type of biopsy that was done here to diagnose the SJSTM, if they knew that's what it was?
The fact that it was a deep and it could have just been a shave.
Yeah. Well, what are you guys doing on consults for SJS TEN ruleouts when you know that's what it is and you're just getting a Cornell bed? What kind of biopsy are you guys doing?
A big, wide one. Not very deep, but wide and I guess long.
But not too shallow either. A broad shave. Okay, so yes, shave your SJS TEN ruleouts broad shave. I like to get just the edge of the normal tissue cut into that dusky area, blister, and all. But don't do this though. Don't get this like little, don't make this your biopsy, right? Because like, how am I going to evaluate the inflammation? I'm not, so I can't see it. So I'm just going to see the depth. But like, this is really what I want to see. I want to see a shave that goes down at least past that plexus, at least past the postcapillary venule. So I want to see that white, when you do your shave, you want to see that white dermis with those pinpoint bleeding with some, it should be just not pinpointed. Your patient should scar. You should give a scar to your patient and you should not care about it. Because now there is not the time to spare your patient from a scar. This is not a cosmetic clinic. It's also not a med derm clinic where we can get away with doing a little Gillette biopsy, or I'm your Venus, I'm your fire. I'm going to get the smoothest shave ever for a little basal cell and hope that you make it on the diagnosis after ordering 2 rounds of 10 deepers. Right? You can sometimes get away with that. You can't get away with that now. Right? So long, broad, and not that shallow. Cool. The other thing, well, we'll get into that a bit later. Okay, so going back to this one. So, okay, so you guys got that. Yeah, EM at the top of the differential. Not a whole lot of involvement or evaluate adnexal structures. It's going to be, it's going to be not exactly going to ask you to differentiate acute graft versus host disease versus EM without some kind of clinical context. I haven't seen them do that, but we'll go over the features of that.
Sorry, Avi, question about the last point. Why is it important that it's broad?
Well, think about it. So when we're looking to diagnose SJS/TEN, we're not always, they're showing you this because this is the money shot. This is like the diagnostic area. I can clearly see all this dead red stuff. I can clearly see there's an enormous amount of death, and I can clearly see that there's not a lot of inflammation. But in reality, we don't always get the picture perfect shot like this when you do a biopsy. Sometimes we just get the normal skin component. Sometimes we just get a bunch of hard to process, like questionable biopsy gook. Sometimes we get something that's on the borderline. And then we'll have to start cutting deeper. So think about it. It's just a principle. If your diagnostic field is at a given location, doing a broad shave just maximizes the amount of tissue you get that is going to potentially be diagnostic, rather than doing a deep punch that goes down to the fat here. Like, why am I wasting my tissue getting fat if I'm evaluating for SJS/TEN? Is there anything I'm going to expect to find in the fat if I know the patient has SJS/TEN? I'm just doing this to get them to Cornell? No. So like, why am I wasting? If I'm going to take a certain amount of tissue off the patient, you want to maximize the amount of tissue you're taking off the patient that's potentially diagnostic. All of this tissue right here, if you knew it was SJS/TEN, like all of this is just useless. Like there's nothing about SJS/TEN that's going to do anything here.
So yeah, Avi, I think that point is great about sampling is a significant issue. And then so pitfall when you do a smaller biopsy for SJS/TEN is that the necrotic epidermis doesn't have much to hold on to, and it's going to float away. And so that's another opportunity that you may have lost in terms of making the diagnosis.
And so if you guys do a punch, those little punches, sometimes that necrotic epidermis can get stuck in your punch. And then you have to go fishing on the other end with a Q-tip to try to push it out and hope you'll save yourself. So always, like, you should be doing shaves. You should try to get us a diagnostic sample. And think about it. You want to do this in one shot. What you don't want to do is go back. Because think about it. If you didn't get if you had a sampling issue or your shave was too small and then it was just all necrotic or something happened to it in processing, or for whatever reason, you're going to go home thinking you did a fine job on your biopsy or whatever, and you're going to get paged again. So you've delayed the diagnosis, your patient's in more danger. You're just going to come back to the ED from wherever you went to for another biopsy. You have one job. When you're doing this, you got one job and one job only. If the diagnosis is there, sample it appropriately so it can be made. That's your job, nothing else. Your job is not to save the patient from a scar. Your job is not to do anything fancier than that. Just if the diagnosis is there, get the appropriate sample to make the diagnosis. Make it easy to process, easy to read. It's not the time to get, it's not the time to do fancy stuff. So yeah, that's the reason. Well, among many.
Thank you.
All right, what about this?
Well, there's some action happening in the middle of but it's pretty small. If we go back on scanning power, it looks like there was some like orthokeratosis there on the left-hand side. Yeah, can we zoom in there? That's clonal lamella.
Yeah. Good. You didn't tunnel vision. I like it. By the way, there's another one here in the middle. See that? What are these?
Just keratotic or necrotic keratinocytes.
Yes. That's another coronoid lamella. So look, we're doing interface, we're looking at lichenoid stuff. So the lesson here is that poro can look lichenoid in the middle. Poro can do a lot of things. So as the line is, the Elstonism is that the middle of a poro can look like anything, basically. So it's important to not tunnel there. Okay, the pattern here.
Lichenoid band.
Lichenoid and? What do we think these cells are going to be?
Maybe a mix of lymphocytes and something else.
Okay, good. That's all I want you to get on this power. Not just lymphocytes. Why is it not just lymphocytes?
I mean, the areas that look a little bit lighter. The whole thing's not like totally blue.
Yeah, lymphocytes are like jet black on low power, at least according to Clay Cockrell. Some people say it's going to be a dark navy, like whatever. I don't care. Jet black. But at least in this case, there are areas where it's more pink. So maybe there'll be histiocytes, maybe there will be something else, but we're going to look for something other than lymphocytes. Any ideas?
Well, they don't really look like histiocytes. We got pigment. It's not so much, there's pigment in the dermis, but it isn't like interface dermatitis.
Good, I like that. So there is pigment in the dermis, but it's not pigment dropout. Well, there's no interface from the epi. So that pigment might be coming from somewhere else.
There's a melanocytes, and we have lymphocytes that are, I forget that term, it's like mingling. So this is a halo nevus.
Good, good. So you got to pick up that there's nesting here. There's nesting melanocytes. And yes, the pigment, you can see pigment in those nesting melanocytes in this case, and they're intermingled between lymphocytes. And this is the classic picture of a halohavis.
But would
Perfect.
you still consider this band-like infiltrate?
It is
Like
a band.
lichenoid infiltrate?
So it's a lichenoid. So this is the example of a band-like or lichenoid infiltrate that is not a lichenoid interface dermatitis.
And what are the other examples of that?
Well, we'll get to them.
Okay.
So look, that's what it is. I mean, are there lymphocytes? The answer is yes. Are they distributed in a band? I mean, yeah, the answer is yes. But is it a lichenoid interface dermatitis? Absolutely not. So it's important to distinguish a band-like infiltrate or a lichenoid infiltrate from a lichenoid interface dermatitis. Those are going to lead you down different differentials. So, band-like infiltrate?
Yes.
Yes. Good. So lichenoid infiltrate, is it a lichenoid interface dermatitis?
No, because you can see the DEJ. Eh,
Use your criteria.
kidding.
Don't remember the DEJ is just to DEJ is just to differentiate, and we'll get to that, but DEJ is not a criteria for whether you can see the DEJ or not, is not a criteria for whether something's a true lichenoid or true interface dermatitis or not. We have 3 criteria for whether something is just
Yeah.
interface
So there
dermatitis.
are dead reds. I do see
Yeah.
dead reds. And I think there's pigment dropout, but it's kind of like a pretty dark picture, so I'm having
Yeah, it's
trouble.
there.
Yeah. Yeah, so it meets the criteria.
Yeah. Okay. So it is a true interface dermatitis. And look, it's a heuristic, not a law. In some cases, you can see the DEJ. Okay. What are we going to do next?
Look for EOs.
Okay.
A lot of plasma cells. A lot of lymphocytes. I don't see any EOs.
Good. There are red cells, but no EOs. Now, also, clinical is important here. Because, what does this look like?
Is it like rook? Is that what you call it? Rook
Yeah, it's
sign
like
or
this
something?
papillated and it's almost starting to form a rook. It looks
this
like
like-
it may be, so it's important what this came in as.
Oh, like a LPLK.
Right. Right. So it's important. So we're going to look to see if this came in as a solitary lesion or some kind of rash. So if this came in as a rash, we have our differential. But as you said, if this came in as a solitary lesion, we're going to think this is an LPLK.
If this came in as a rash,
Mhm.
it could just be lichen planus then, right? Like what is it missing any lichen planus criteria?
That's exactly correct because
Okay.
it is very difficult. So, some people say they're good at it. Other people say you don't know what you're talking about. You're not good at it. You think you're good at it. But it can be very difficult to distinguish lichen planus from a lichenoid keratosis. And the number one way to distinguish it is clinical. If it's a solitary lesion, it's an LPLK. If it's a rash, especially if you get the classical features, it's lichen planus. But in this case, I'm giving you a little bit of a hint because you can almost kind of see that this is like somewhat of the architecture of a seborrheic keratosis that's being chewed out. So in this case, it's a solitary lesion and it was an LPLK. Sometimes you can try to look to the side of the lesion and see a residual seb-K. That doesn't always work. The biggest differentiator is your clinical. Okay.
Just from like a bird's eye view, you can tell that we'll punch biopsy lichenoid lichenoid infiltrate. You have to go in deeper to see if there's any like dead reds or pigment dropout. I see the pigment dropout. I see the dead reds and the vacuolization. So this is a true interface dermatitis.
Yeah, it is. Okay. Any other things you want to do?
Let's look for EOs.
Okay.
See some EOs there.
Good.
Oh yeah. So then lichenoid drug eruption.
Yeah, this is good for lichenoid drug. I agree. Other things you can start thinking of like hypertrophic lichen planus if there's a lot of hypertrophy. And some say that you can see eosinophils in lichenoid drug as well. I mean, sorry, hypertrophic LP as well. But in this case, the findings are best for, yeah, there's even more EOs over here. See those? This one and this one. This one here. So this is good for a lichenoid drug eruption. But good, you knew exactly the algorithm. You knew the previous. Perfect. Let's take this top part first.
It
See,
looks just
So
more
it's
like
perivascular.
surface one.
More perivascular than anything, yeah.
yeah, it's on
What's going
volar
on up
skin.
here?
Are those slender ready ridges?
Not really. In fact,
Okay.
what site are we on?
Volar
Volar
skin.
skin.
Volar skin. This is kind of normal for volar skin. Maybe a little psoriasiform, but not particularly that slender picture for something you'd see in syphilis. So maybe a little vacuolization, but do we have any true interface dermatitis?
No, it doesn't seem like it. I don't see any dead reds and I don't see any pigment dropout.
Okay, good. Now we do see a superficial perivascular, but what do we see? What's going on over here? This doesn't look particularly that normal.
Yeah, the dermal papilla look weird.
How so? Yes, I agree. They do look weird. In what way are they weird?
There's just like a bunch of like inflammatory cells in there. And like the spongiosis and edema.
Yeah. Now look at this though. Like you say edema, and so where's the edema more? Is it like spongiosis? There's a little bit of spongiosis, but is it more spongiosis or just more like edematous papilla?
Edematous.
Edematous papilla. What do we call that? If there's
Papillary
like in the
dermal edema.
papilla. Go ahead.
Papillary dermal edema.
Yeah, papillary dermal edema. Good. So there's some papillary dermal edema here. And something else is going on. There's the superficial, is it just superficial perivascular?
Oh my god, the eccrine glands are crazy.
Whoa, yeah. How are
It
they
says
crazy?
perniosis.
Yeah, good. So what's tipping you off for pernia?
Volar
It's
skin.
the superficial. As a superficial and deep perivascular and periacrine on the acral skin,
Okay.
as well as the papillary dermal edema.
Yeah. Now, to be clear, the way this is a classic way they test it. You can theoretically get pernia on non-acral sites. I think we've actually had a case where someone was taking an ice pack to their trunk somewhere or to their abdomen or back, and they got pernia on their back, and it looked just like this minus the acral features. So yes, and you can see that this is like tracking up the eccrine units, even like when you see. Let's see if I can get a good one. Sometimes if you get deeper, you can see like the eccrine duct, and if you can even track it all the way up, and it's really just inflamed all the way up in some cases, which is kind of cool. But yeah, good job, Perdia. Okay.
So this looks like a true vacuolar interface dermatitis.
Yeah, true vacuolar interface dermatitis. Okay.
So then next we're gonna look for the EOs.
Okay. Are they there?
Yes.
They are there. Okay.
The horn is very much an acute horn because it's
Yes.
basket
Good.
weave. Yeah.
Okay. No, you're on the right track. Horn is acute.
Yeah, so based on what items are in our differential here, with an acute horn, let's say you were considering fixed drug because they're EOs, you would
Perfect.
look to see if there's any chronic changes in the dermis.
Are there?
And yeah, it does look like there's some chronic changes in the
Yes,
dermis.
look at how deep the pigment runs deep. So clearly something's been here before, right? Pigment runs deep. It's took some time, and the horn is completely acute here. So there's a just temporal discrepancy between what the dermis is telling you and what the horn is telling you. And how do we put that all together?
Fixed drug eruption.
Fixed drug eruption, first time or not first time?
Not
Oh,
first.
not first time.
Not first time fixed drug eruption. Exactly.
That's interesting.
Fixed drug that's been here before is what this is. Perfect. We did this.
So,
That's our
so Avi, what would be the answer for that? Like, would it just be like fixed drug eruption or
it would be fixed drug eruption. I haven't seen either on cores or boards them say fixed drug eruption second occurrence. But just so you know, there is if this were a first occurrence, then you may not have this discrepancy. The reason you have this discrepancy is because it was here before.
Got it. So then if this I just forgot what our lichenoid drug eruption slide looked like. Like the horn of that one looked different relative to this one.
Sure.
Oh yeah, it doesn't look so basket weave. Okay, cool.
Yeah, it's ortho, but it's not. It is not a perfect basket.
Yeah.
There's a reason. Now, in real life, you may not get everything that's perfect, but on the exam, there's a reason they're putting this here. They're trying to make the point to you, and they're
Yeah.
trying to see if you're going to spot it.
We're not trained to be dermatopathologists.
They know that. Okay. They know that. That's why they're doing this. Why, like a lot of very classic examples of not so common things come up on the boards. But that's not true. You're all training to be dermatopathologists because you all love dermatopathology. Okay, you all realize that is objectively the best field within both pathology and dermatology.
I agree.
Yeah, Jonas agrees. See? Okay. Did we do this one? I think we did this one. We did. Okay, it's just another one. Okay. What about this one?
There looks like there's some perivascular infiltrate both superficially and deep. But I also see some inflammation around the DJ, so it seems to be obscuring the DEJ. There are vacuoles and there are dead reds and some pigment dropout.
So it's
it
a
seems
true
we have
interface dermatitis.
a vacuolar interface dermatitis with superficial and deep perivascular infiltrate.
What's going on with your horn?
The horn is parakeratotic.
Yeah, it's got some neutrophils in it. It's got that dirty
Yeah.
parakeratotic horn. Just a few of them are confluent.
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 It's like all
Broad
those
front.
things.
Okay, so you have confluent parakeratosis over a broad front. You have a band-like or lichenoid or vacuolar interface dermatitis. There are other cells that are not EOs here, which are
Erythrocytes.
Lymphocytes.
okay. The
I
infiltrate is what shape?
What shape?
Okay.
V-shaped.
Oh,
V.
Priva.
Okay, you know what time it is, guys.
Oh my god.
You know what time it is. Okay, you gonna do it with me? You gonna answer when I do it?
Yeah, sure.
Okay, give me a P.
P.
Keratosis.
Oh, actually naming it out. Okay.
Parakeratosis over a broad front. Give me an L.
Lichenoid
Lichenoid.
infiltrate.
Great. Give me an E.
Extravasate
Erythrocyte
Extravasate
extravasation.
erythrocytes. Give me a V.
V-shaped dermal infiltrate.
Yeah.
Give me an A.
Acute epidermal changes.
Okay, what's that spell?
Viva.
That spells pleva. See that? Killed it. So I was a cheerleader back in the day. Not the type of cheerleader who threw the girls up, of course. No, I had the pom-poms. Okay. So we made the pleva cheerleader song. That never happened. All right. What about this one?
I think, well, just looking at the epidermis first, which I know is not the best way to start, but actually, no, I'll rewind. I think this is diffuse. The infiltrate here is kind of diffuse. It looks like there are inflammatory cells in the superficial and deep dermis, and they don't look like they're concentrated around vessels.
Yeah, there's
They're
definitely
just
an infiltrate.
everywhere.
What's wrong with this infiltrate?
It's like mixed. It's like histiocytic and I think there's actually like a mitosis like right there. What
Yeah.
what the hell is that? Yeah.
Looks like a bird, right?
Yeah.
There are definitely EOs also.
Yes, there are EOs. Not just red blood cells. Okay.
But it's not just at the DEJ. I mean, it keeps going.
Oh yeah. Yeah, it does.
It's
Yeah,
everywhere.
Whatever this is not good.
What are
And
we
then the
thinking?
horn, sorry, not the horn, the epidermis looked acanthotic.
Yeah, there might be some reactive changes there. I agree.
Not interface dermatitis, though.
Yeah, I don't think it's an interface dermatitis. Okay. So what's our what are we thinking then?
Oh, we're thinking like something neoplastic.
Yeah. I mean, you see all these, tell me about these nuclei.
Hyperchromatic.
Yeah. I mean, hyperchromatic nuclei, what kind of cells do you think they are? There is a little bit of what's appearing. Here's another mitotic figure, by the way. Sometimes you could see some epidermotropism.
Oh, is this like MF?
So, I mean, it's not MF, but it's related. Like these are lymphocytes, but notice what's wrong with these lymphocytes. They are, one thing you mentioned, they're hyperchromatic. They're quite large. They're atypical. We have to start thinking about some things here. And if I just showed you pleva and told you this patient, this patient might have a dirty pleva cousin.
Like PLC?
PLC is not the dirty plebicosm. It's more of a benign. It's more
Oh,
of a
LYP.
LYP. Okay, so
Lymphomatoid
LYP.
papulosis.
Okay, so we have to think about LYP here. You know, you can worry about large cell transformation of MF. You can worry about LYP. What are we going to do?
Staining.
CD30.
Okay, we're going to stain. We got to work this thing up. So how are we going to work it up? CD30. I heard good choice. We're going to do CD30. What are we? Anything else we're going to get? How do you know it's T cell? Maybe it's B cell.
Oh, so like CD3.
It's
See it like CD3.
CD8.
Okay, see, we'll get some T cell. We would get some T cell markers on
T
this.
cell
I mean,
markers.
if it's
CD3,
MF, you worry about large cell
CD4,
transformation.
CD8.
Okay, CD3, CD4, CD8, 5, 7, 10. Sorry, 30, 20, and 30.
20 and
By the
38.
way,
Uh-huh.
if you're worried about like anaplastic large cell, there is a stain you can get that can sometimes help you, which has a very similar acronym as anaplastic large cell. It's called anaplastic large lymphoma kinase or something. AL.
ALK.
ALK. Yes, ALK1. Like I think that's like anaplastic lymphoma kinase or something. But yes, okay. So that would be a good workup for this. Cool. Once again,
This is an interface
Pleva.
term.
Pleva, yes, good. Burning it into your mind, recognizing the good horn, the horn for the pleva, parakeratosis over a broad front, that dirty confluent parakeratosis, and all the other features that you're recognizing now. Good. Burning it into your mind.
Avi, on that last case of the LYP, would the answer choice then just have like LYP? Like, how would we have known? We would have just, I guess, known it from the fact that there were those like mitotic figures, the busy, like the fact that the dermis was.
They're atypical lymphocytes here. I mean, you look, even if you didn't see a mitotic figure, like you're looking, look at these cells. Like these are not normal.
Yeah. Okay.
Okay. We're getting to a band-like. See if it's better in any. Oh, here, maybe here. So someone asked what else might be on a differential for a band-like infiltrate. That's not. Well, let's decide. Is it an interface dermatitis? This is blurry over here. Let me go to another cut. Unfortunately. Oh, here we go. This is better. Okay. Interface, true interface or not?
It doesn't really look like it.
Yeah. Is it vacuolated?
Yeah.
Okay. We're missing the other stuff though.
Yeah, the dead reds and the pigment and pigment dropout.
Yeah. What do we have?
The superficial perivascular infiltrate.
Okay, there is a perivascular infiltrate. What else is there?
It looks like there's cells in the epidermis that aren't keratinocytes.
Good. In fact, these cells kind of look like the perivascular cells. Just a little bit more atypical, maybe a little larger and haloed out.
This is epidermotropism.
Epidermotropism. Very good. And here we might even start coming to something like
Like a micro abscess
Like
or
a like a microabscess. What do you call lymphocytes when they become epidermotropic to the point where they start forming microabscesses?
like Mischner's corpuscle or no?
Yeashters.
Pautier's
It's a normal
micro.
structure.
That's a Paudier's abscess.
Pautier's
Pautier's.
microabscess. Very good. All right. Okay. So what are we thinking?
This is MF.
This is good. This looks really good for MF. Some other things that you might find due to the chronicity, you might find what's called the fettuccine sign. You might find some fibrosis or sclerosis of the just underneath the papillary dermis, which is thought to be this chronic process of the lymphocytes coming from the plexus, the postcavitary venules, migrating up to the epidermis. When that happens over and over again, it becomes a chronic process, and so you get that.
Do they call it like the pigs lining up at the trough?
I'm
Sign.
sorry?
Pigs lining up at the trough.
Pigs lining up at the trough. The other thing, so lining up at the trough, you mean, are you referring to these, like how they're all like lined up over here?
Yeah.
Yeah, so pigs lining up at the trough, or that the other phrase, the Elsonism for this is, see how they're all vacuolated and they're all, so the epidermis is vacuolated but not true interface dermatitis, and they're all plucked in with the lymphocyte.
Like the
So he calls
bear
that
under the belly.
a lymph in every hole.
Oh.
That's the other phrase for that. So that's another classic finding they may give you for MF. But yes, this is about as good as MF as you'll get. What are you going to stain this with if you were to do an MF workup?
4 and 8 and 3.
Okay, CD3, CD4, CD8. What else?
Perhaps CD30.
Okay, if you're worried about large, okay, so like LYP or any large cell transformation, fine, CD30. What else?
CD2 and 7.
Yes, you want to do CD7. Why do you want to do CD7?
I think it's the one that's usually lost first.
Yeah,
Yeah,
and
so
it
you're gonna
also is like indicative of like prognosis.
Yeah, so the thing with so CD7 is always a little bit diminished compared to the CD3, CD4, but sometimes you can see a strong diminution of CD7, which is a good clue to the diagnosis. So you can look at the epidermotropic component on the CD3, and you will see your strong epidermotropic component, but then you look at CD7 and it's like, there's no staining in the epidermis. It's just gone. And that can be helpful. And if we're not talking about immunohistochemistry, what other tests can we do?
TCR.
TCR. And by the way, how do we do TCR? And this is a question on this might very well be a question on the core exam. I can tell you that. What's the mechanism that they do TCR with? Is it a fish test? Is it
Like the CGH or it's
like
no,
what kind of molecular test is it?
it's like a gene rearrangement, TCR gene rearrangement.
How do they detect that?
Magic.
I'm sorry?
Magic.
I thought it was TCR.
The fish, probably.
It's not fish. By the way, what do we
Dang.
use fish for?
Can't you do that in spits?
Okay, we use fish for spits. What other things do we use fish for? What could we?
Like gene translocations.
Yeah, translocations. Like what kind of tumor might we see that is a translocation tumor in Dermpath?
DFSP.
A DFSP. You could do fish on a DFSP.
Col 1A1,
Yeah, for col 1A1.
PDGFB.
Yep. Okay. PGDF beta col 1A1. If you have breast cancer and your HER2 is indeterminate, you can do a fish for HER2. Okay, but that is a translocation. Do you think that we're looking at translocations or chromosomal abnormalities when we're deciding to look for a clone for TCR?
PCR.
PCR, yes, that's what the answer is. We do it with PCR. TCR is done with PCR. Exactly. So yeah, they amplify the gene in question to see if there is a clone of that gene. And if there is a rearrangement and a clonal rearrangement. That's how it's done. you won't be able to do that on a fish because it's not just going to reliably show up on. It's not like a named translocation or a reliable chromosomal abnormality that's going to determine that specific gene rearrangement. Okay. Band. True interface dermatitis? Or no?
No.
No. What kind of infiltrate?
Lymphocytic mixed.
Need some plasma cell there, right?
Yeah,
Some?
a lot.
A lot. A lot. In fact, that's the main cell. And you don't have that amazing, sexy, slender reedy, so I guess it's not syphilis, right?
Right.
Yeah. So we don't need to do like a Spyro or anything. Any newts in the horn?
Yeah, there was some parakeratosis, but it didn't look confluent.
Doesn't need to be confluent. We're looking for, and we're also not just para, we're also looking for newts.
Newts specifically, yeah.
Yeah. So you saw some newts in the horn. What's the differential for that? What's your differential for newts
Is
in the
it
horn?
catnips?
Yeah, I like C tips, Candida, tinea,
C-tips.
impetigo, psoriasis, sebderm, syphilis.
Yes.
Is a good one. So I'm just going to say that a few times to burn that into your mind, even though it's going to be annoying. Newts in the horn. Candida, tinea, impetigo, psoriasis, sebderm, syphilis. Candida, tinea, impetigo, psoriasis, sebderm, syphilis. Candida, tinea, impetigo, psoriasis, sebderm, syphilis. C tips. Candida, tinea, impetigo, psoriasis, sebderm, syphilis. Okay.
You just do it one more time though.
Okay, Candida, tinea, impetigo, psoriasis, sebderm, syphilis. Okay, very good. So what is this?
Thank you so much.
All right, you're going to get a word. All right, what are we going to do? What's your approach here?
So start from Candida.
Okay.
Candida, you would probably see the diving fungi.
And there's no diving fungi here.
There
If
are
you
no
wanted to make
diving
it sure,
fungi.
if you wanted Pertinia and Candida, if you wanted to make sure, what would you order?
PAS.
A PAS. Good. PAS will light it up. Okay. In Impetigo, do you see any bacterial colonies?
No.
Okay. Psoriasis. Does this look like psoriasis with
No,
all
it's
these
not.
plasma cells?
Not thick, and it's just not really a slam dunk for psoriasis.
What does this look most like out of everything?
Syphilis.
Syphilis. That's what it is. So syphilis has mixed features. So there's a mixed reaction pattern. So it's not psoriasis, but there's some psoriasiform hyperplasia. And there's psoriasiform and like a lichenoid band-like infiltrate. So there's like a mixed reaction pattern here. So you got to have your antenna up for syphilis. And with all those plasma cells, that also really goes for it. So you got to get spirostain, and it would be best to get an RPR on this patient as well. But that's what it was in this case.
Question. So I noticed there's no granular layer. Is that a giveaway that this is probably a biopsy from the genital area? I forgot.
No granular layer or diminution of the granular layer?
Diminished granular. Oh, actually there are. Yeah.
Yeah, just as a general rule, many times when you have parakeratosis, you can get a diminution of your granular layer. There are violators for that. Okay. Give me an example that violates that.
Oh, like mucosal skin?
I'm talking about a disease that violates that. Mucosal skin, you don't really have you don't have
Oh,
para
well,
because you don't have
clarify.
you don't have your stratum corneum either, right?
Ichthyosis. Vulgaris.
Okay, so ichthyosis vulgaris, what do you see?
Ortho
You have-
So it's ortho, and even though you have ortho, you don't really have a granular layer.
Yeah.
And what about the reverse?
Granular parakeratosis.
Parakeratosis, right? You have all this parakeratosis, and you definitely have retention of your granular layer. Yeah. But in general, when you have parakeratosis, less granular in the areas of the para. So again, have our old friend, our band-like infiltrate.
Well, this one doesn't have
By
a
the way-
sternoconium.
Yeah, this one doesn't have like a whole lot of stratum corneum.
You got some what muscle down there in the dermis? What is that?
Okay,
Looks like
we're gonna figure it out. What's this?
Erector pili?
Come on.
No, it's not
Erectopyly.
hair.
This looks
It's
like
not hair.
this, doesn't it?
There's no hair. Yeah, no, it's
is that nerve?
Nerve.
it looks
And
like
this?
Smooth muscle.
Doesn't this look like this?
Also nerve.
Also nerve. And I'm gonna I'll show you guys some smooth muscle and erector pilot. But look, you see how the nuclei we get in cross section? Look at this. See how they're wavy?
yeah,
Yeah, this is like a wavy, nervy nuclei.
yeah.
Burn this color in your mind. Like this is like the color of a nerve also, and that's that stroma in between the wavy nuclei. Nerve. This might even be part of the same nerve. And here, more nerve. Even more, and this is,
Nerve.
and this is
I got nerve.
the nerve of this thing. Okay. Okay. Does that help? Is there any location that might have like an incredible concentration of nerves?
Glands or clitoris, maybe?
Yes. The glands of the penis or the head of the clitoris. Yeah, exactly. The clitoris or the head of the glans penis. Exactly. So that's very helpful. Areas with the highest concentrations of nerves. And then what else are we seeing here?
See the like the keratinocyte look like very flattened or like a diamond shape.
Diamond-shaped keratinocytes.
Paget's?
Paget's. What do we see in Paget's?
Or Zuhn's balanitis. Is that Zuhn's balanitis?
Zuhn's. Yes.
Zuhn's.
Okay.
I get those confused.
Listen, hey, you're not going to get it confused anymore. All right. Zuhn's balanitis, those diamondback keratinocytes. What do we see? What kind of infiltrate, by the way, do we see in here?
Plasma?
Plasma cells. There's plasma cells in here. Sometimes you can also see eosinophils. Even in some books that have these descriptive pictures of Zuhn's balanitis, I see eosinophils, and I think that I found some eosinophils in this case as well. But yeah, this is Zuhn's balanitis. Anyone know the etiology? What do you guys think the etiology of Zuhn's balanitis is?
Well, isn't it like, because like circumcision is like curative. So it's like, isn't it like irritation or like poor hygiene or something?
Yeah. Dirty. Poor hygiene. Okay. That's at least what my understanding is. So it's like an irritant. I won't belabor the point. This is another fixed drug. Okay. Interface dermatitis, true interface?
Yes.
Yes. What's happening to the adnexal structures?
They're also affected.
Also affected.
GVHD.
Yeah, so it's a coup for GVHD. In this case, it is GVHD. Some other things you can see. Have you guys heard of like satellite necrosis?
Yeah.
Is that a specific finding for GVHD?
I don't think so.
It's not. Not a specific finding for GVHD. Some other findings that have been described in GVHD is like basilar atypia, which is probably just reactive. And you can see that over here, how these the cells of the basal layer over here in this case of GVHD are a bit atypical. And then there's variants of GVHD that you can see. So like, what would this variant be? And they'll give you some history. They're not going to ask you to differentiate this from like just plain old like, you know, any other lichenoid process without something. But like, what would you be thinking here?
Lichenoid GVHD.
Lichenoid GVHD. Is there another type that you're responsible for chronic GVHDs?
Sclerotic.
So something like this,
Period.
sclerodermoid GVHD. And again, they're not going to just give you this and say, "Oh, can you differentiate this from Morphea?" Like, no, that's that you're not responsible to do at that level. They'll give you something in the questions, but you have to know that there are chronic forms of GVHD that are lichenoid sclerodermoid. It's also like lichen sclerosis like, and there's some even rarer variants. Okay, and is there interface?
No. No, wait, no, yeah. That's a dead red.
Dead red. It's not extensive, but it's
There.
there. And there's also pigment dropout, by the way.
Can you point out the pigment dropout?
Right here. See it?
Yeah.
And here. And here. And here.
And there's a lot of blue in the dermis.
Yeah, there's stuff in the dermis too. Okay. What's the blue?
The black lymphocytic.
Yeah. Oh, by the way, here's some more dead reds in case anyone wants it. All right. Here.
Pigment dropout too, yeah.
All right. Lymphocytes. Where are the lymphocytes?
Perivascular, also maybe, I don't know. Superficial and deep perivascular.
Superficial perivascular
Periacrine.
and periacrine. So, sparse interface dermatitis. There's also some spongiosis. Spongiosis, interface dermatitis, superficial perivascular, periacrine. When you see that combination, there's really one diagnosis you should like have at the top.
Lupus.
So lupus is okay. So lupus is in the differential here. What's not as good for lupus? And I realize that we don't have other adnexal structures here to compare this to.
I think you should expect to see more mucin and the follicular plucking if it is chronic.
If it's discoid variant follicular plucking, if you have the follicles, sometimes you can't really see good mucin. It's definitely on the differential. The thing with so there's an interface dermatitis. We have to be thinking about connective tissue diseases. This is a little spongiotic, and this entity tends to be a little more spongiotic. It's also really just periacrine. If I were to just tell you that there were follicles here, there were other adnexal structures that were not really involved.
Is that like lichen striatus?
Good, yeah, lichen striatus. But yes, lupus would be obviously lupus would be the other thought here. So lichen striatus, you do see spongiosis, but there also is an interface dermatitis, although it might be subtle. There also is a superficial perivascular, but there's also a peri. The key thing is a periacrine. As opposed to this. Interface dermatitis.
No.
Yes.
Vocal.
Okay. There is an interface dermatitis. It's not very pronounced, but it's there. And there is pigment dropout. And then what else? What other patterns do we have?
Superficial and deep perivascular.
Superficial, deep perivascular, and
Adnexal.
adnexal, not just periacrine, right? Acrine are involved, but
Yeah.
also what else is involved?
Hair.
The hair.
the hair.
This would be discoid lupus.
What do you think? Yeah, so this is, well, the thing with
More lupus favored.
lupus, yeah, this is actually, what do you guys think this is? All this stuff here is
Mucin.
mucin. Okay, so it's a very sparse interface dermatitis. Does that go well with discoid lupus?
No, that would be discoid lupus is more.
Yeah, think about it. Like discoid lupus, does it scar?
Yes.
Yes.
LE, does it scar? Or SCLE, do they scar?
Yes.
No,
They do not.
they do not. The lead by post-inflammatory pigment alteration, they don't scar. DLE scars, and so that it goes with that interface dermatitis being much heavier, much more brisk. Other things you look for if you're looking for DLE will be like things like follicular plugging, thickening of the base membrane, which you'll ideally evaluate on a PAS, not on H&E. And if I wanted to light up the mucin, what stain would I do?
Colloidal iron.
Colloidal iron. Yeah. Okay, good. All right. And then we'll have a whole lecture about lupus and all the different variants, so don't miss out. But you guys did great. Good job. There's some interface.
Thank you, Avi.
Have a good one.
Thank you.
Thank you.